All right, so you know what Dr. Weber and Dr. Pavlik and everyone has told us that since 2011, the treatment for melanoma has been revolutionized. And so while we have seen a number of successes and continue to see those and continue to build on those, we certainly have to take pause and understand what side effects come and what kind of toxicities come with these treatments. And so like they said, we've seen unprecedented progress in success in melanoma, and it sort of takes the form of two aspects of treatment. So one is the immune checkpoint inhibitors, and one is targeted treatments, targeted therapies, targeting the signaling pathways that are important in melanoma cells. And so each of these come with their own unique side effects. Some are similar, but some of them are very unique and specific to the treatments. So like Dr. Weber told us, we've made strides in inhibiting the inhibitors of the immune system. So just to remind you, the CTLA-4 blockade with ipilimumab was the first immunotherapy that was approved in melanoma, and it inhibits one of the what we call the stop signals in the immune system. So essentially you block the stop sign, rev up the immune system, like putting your foot on the gas pedal, and it keeps going and going and going. And this is really in the activation phase or priming phase of the immune system. And then the effector phase, which is the PD-1 blockade or the PD-1 pathway, is the other side. And so here you have T cells that are then able to act on the cancer cell. Again, you're inhibiting a stop sign, putting your foot on the gas pedal, revving up the immune system. So what happens is the immune system attacks the melanoma, but sometimes it gets confused and it attacks normal cells as well. So many of the side effects we see are all immune mediated because we've revved up this immune system. And so there are some side effects that are extremely common, and there are some that are very unique. And so one of the common side effects we see is fatigue. And we see this in about 40% of patients treated with what we call immune checkpoint inhibitors. We can see fever, we can see nausea, we can see anorexia or appetite suppression. You can see muscle aches known as myalgias. And about overall, patients report these side effects about 20% of the time. So the other thing that we see, because we're revving up the immune system, we sort of create this inflammatory state in a patient. So a lot of what we see are these inflammatory side effects, a lot of the itises and the apathies. And a lot of organ systems themselves can be affected. So we see a lot of the skin toxicities, GI toxicities, and the endocrine system gets affected. Less common, but certainly we can see it, and we take pause because they can be serious. We see a lot of issues with the liver, the respiratory system, the nervous system, and we worry about ocular toxicity as well. And so usually there's a characteristic onset. We usually can see skin toxicity first, followed by GI toxicity, and then the liver itself, and then endocrinopathies tend to be later. But while we can sort of predict this, what we do know is that there is a rule of unpredictability in all of these side effects. So again, onset is typically 6 to 12 weeks after we start immunotherapy, but really it can occur at any time, any number of days, weeks, or months after therapy. And we actually monitor for these toxicities even years, 1 year to longer after treatment, because we know that these side effects can still manifest themselves. It doesn't have to be isolated to one organ system. We can see multiple side effects happening at the same time. Some of them can be extremely mild in patients, while you can see extreme toxicity after even one dose. And a lot of times the dosing, the frequency, and are we combining these therapies, how that affects the toxicity as well. So Dr. Weber sort of talked to us about different types of immunotherapy. So we certainly have treated patients with single agent ipilimumab, that's CTLA-4 antibody. We certainly use in PD-1 inhibitors alone very frequently, and now we're starting to we're combining that ipilimumab and nivolumab, or the PD-1 inhibitor, together. And we see different side effect profiles with these drugs. So ipilimumab tended to have a lot of colitis, and we would see some other manifestations. The PD-1 inhibitors seem to be a little more gentler and have less side effects compared to their individual counterparts, ipi or the combo. You see about 16% overall. Still see colitis, skin, endocrinopathies, and liver. And we see significant toxicity when we put the two of these together, because we're actually affecting both parts of the immune system, so revving up the T cells, as well as then letting those T cells act on the tumor cell. So you can see about 56% rate of side effects. Again, colitis, the skin toxicities, and we do see a lot of liver toxicity with the combination therapy. So it's easier if I just put a picture of a body and we talk about it in that respect. So we see a lot of GI toxicity. You can have symptom-wise, you can have gas, you could have just increased stool, you could have change in stool consistency, you can have diarrhea or colitis. We also worry about the lungs, so we definitely can see a pneumonitis, which is an inflammation of the lung tissue. So you can see a lot of shortness of breath, patients who get short of breath on exertion, so all of a sudden they're short of breath walking a block. You can see decreased O2 saturation when you're in the office and we're monitoring your pulse ox. From a hepatic system, you can see your liver issues, so you can have right upper quadrant tenderness, you could potentially have nausea, jaundice, and you can see this immune hepatitis, which we see on labs with an increased liver function tests. We certainly watch your kidneys because you can end up with like inflammation of the kidneys. So those manifest on side effects. Maybe you might see, those manifest in lab tests, but you can also potentially see some blood in your urine or have just dysuria, so painful urination or changes in your urinary frequency. We certainly see a lot of side effects with the nervous system. You can have like what we call neuropathy, so numbness, tingling in your hands and feet. We worry about weakness, muscle weakness, all due to nerve problems. So difficulty standing up from sitting down, or just like overall weakness over time. And then certainly we talk about skin toxicity, so we can see maculopapular rashes. These can be diffuse, full body, they could be scattered, they could also be very specific in one area. Like Dr. Weber was saying, this one woman had just a breast involved. You can have itching, and then you can have worsening rashes called toxic epidermal necrosis or Stevens-Johnson. So from an endocrine perspective, there's a number of specific organs that fall in this endocrine system. So one is the thyroid. So we typically see hypothyroidism, meaning your thyroid isn't working. So patients can be fatigued, they can gain weight, you can have a lot of dry skin, you could have cold intolerance, your heart rate could become irregular, you can have thinning hair, you can have constipation. Rarely, but we do see it, you can actually have an overactive thyroid, so hyperthyroidism. So patients develop palpitations because their heart's beating so fast. Here you see weight loss, you have increased energy, you have nervousness, tremors, because the system's overworking. We were talking about the pituitary gland, which sits right in the middle of your head, right behind your eyes, and it regulates a number of hormonal axes. So this can get inflamed. Dr. Weber had the picture where there was inflammation on the MRI. These cause headaches, they can cause vision changes, they can cause double vision, you can become confused, you can have some dizziness. And then the adrenals sit right above your kidneys, and they are responsible for helping you maintain your normal body functioning. You're getting up in the morning, getting up and going. Your fight or flight response arises from those adrenals. And so without them, you can have fatigue, your blood pressure can be really low, so it can cause you to be dizzy, faint, pass out, just feel kind of yucky. The other toxicities we have, so we talk about a lot of neurological issues. So again, you can have the neuropathy, numbness, tingling. You can also have problems with motor, being able to do fine tasks like button your buttons. You can have muscle weakness. We have seen myasthenia gravis in patients who get these medications. We certainly manage everything depending on how severe the side effects are, but generally we manage with steroids. Like I said, we watch for ocular toxicity. You can have some scleritis or uveitis where you have inflammation and irritation of the eyes. We also see inflammation of the pancreas called pancreatitis, and again, it's on lab values we see these. Your lab values can drop, so we watch for your white count, your red count, and your hemoglobin, your platelets, and we look for renal toxicity. So again, you get inflammation of the kidneys called glomerulonephritis, and we certainly watch for any kind of cardiovascular or vascular issues themselves. So we always run a lot of lab tests when you see us, right? Everybody comes into the office, the lab work is the first thing you get, then you see one of the doctors or one of our great nurse practitioners, and so we always get standard of care labs, but then we get labs specifically tailored to look for some of these side effects. So again, we get all the blood counts, all the chemistries, We do get liver numbers. We do watch the kidneys. Again, that's part of the standard of care labs. And if we need to, we get labs specifically looking for the pituitary. We always screen for thyroid issues. If we have a suspicion that there's some side effects, we look at what the adrenal function is doing. Same thing with pancreas, and then cardiac as necessary by you telling us the signs and symptoms that you're experiencing. So I thought pictures are really worth 1,000 words, and I really do have to give Kathy Madden the credit. I have a lot of her slides, so thanks to Kathy. So this is a skin rash in one of our patients. You can see it's really diffuse along the back. This is one of the more severe skin rashes, toxic epidermal necrolysis. This is where it's such a bad rash, sometimes the skin can slough off. Here is one of our vascular issues. So this is actually a vasculitis where you get inflammation and restriction of your capillaries. So you have poor blood flow here. This is purple to black actually in person. Here's a picture of pneumonitis here, and these are pictures of colitis. So, you know, the big thing is monitoring and knowing to look out for these symptoms and to take care of them as soon as possible. So one of the things to do is always just assume a new symptom is related to the immunotherapy you're on until you've proven otherwise. And so you have to investigate and rule out any other cause of these symptoms. And again, to remember that multiple organs can be affected at the same time, and early identification and reporting and intervention really make a difference. So just like Dr. Pavlik said, our patients sometimes don't want to tell us they have these side effects because they're afraid we're going to stop treatment. And what we really try to reiterate to them is our goal is to keep you on treatment. So the sooner you tell us, the sooner we can intervene and manage the side effects so that we can continue to treat you. So one of the things we do is we generally grade the side effects, and so you know, generally we give it a number or sort of mild, moderate, and it really depends on the grading of the side effects what we end up doing. And with immune therapy, everything is because we've ramped up your immune system, so what we want to try to do is turn the immune system down. So if something's really mild, sometimes we don't even have to change any therapy. If it's asymptomatic, if it was only for on a diagnosis, we can give supportive care and usually continue immunotherapy. For moderate, we sometimes hold the immunotherapy. If we need to, we can always give steroids, usually either prednisone or dexamethasone. And for pneumonitis, that's very severe, and we generally hold though if it's moderate, and we give 1 to 2 mg per kg of steroids a day. Generally speaking, once everything resolves, we can taper the steroids and then restart immunotherapy. For something that's very severe or grade 3, we discontinue immunotherapy. Sometimes patients need to be hospitalized. The endocrine grades 3, we're actually able to restart once everything has stabilized, because with the endocrine system, the gland is generally destroyed, so we have to supplement back the hormones, and so we can continue with treatment at that point. And then grade 4 is very severe or life-threatening. We do not retreat with immunotherapy. Most of the time people have to be hospitalized to stabilize them, and then we treat with steroids and any other appropriate measures to take care of the symptoms that patients are experiencing. This happens very rarely, but it does happen, and that's why we inform all of our patients this is potentially a side effect. You know, one of the things when we give these medicines, it's a risk-benefit ratio, and obviously if we're treating your metastatic melanoma, the benefit of these drugs far outweigh the risks, and so that's why we are very diligent in monitoring for these side effects and treat as appropriately as soon as possible. So the other side effects that we worry about are those that come along with targeted therapy. So just to refresh your memory, you know, we use targeted therapies that target what's called the MAP kinase pathway. It's important in melanoma. You have signaling from the outside of the cell to the nucleus. As Dr. Pavlik pointed out, BRAF V600E is the most commonly mutated gene in melanoma. It's about 50%, and we now are treating with a combination of BRAF and MEK inhibitors here. And so these also have side effects, and Dr. Pavlik talked about them a little bit, and so we can certainly see GI side effects. This is not the presentation that all right, anyway, we'll go with it. So we certainly can have nausea, diarrhea, liver function tests, right? So we have liver abnormalities, so you can have tenderness in the liver. You can also see colonic polyps. So you can also have general constitutional symptoms. So again, so the musculoskeletal system, you can have muscle aches, joint aches. You can have ocular toxicity, which is uveitis. And then constitutional, like we said, you can have fevers called pyrexia. You can have swelling. You can have loss of hair, fatigue. And then what we are starting to see with these treatments now is we actually can start to see secondary malignancies. So RAS-mediated leukemias and colon cancer. And then from skin-related toxicities, we can see macular or papular rashes, again, either diffuse or localized, pruritus, like Dr. Pavlik was talking about, you can have hand-foot syndrome, photosensitivity, squamous cell carcinomas, and then also new melanomas. And so here are some pictures. So here's again a picture of one of these macular papular rashes on the back, these warty-like growths, as well as the squamous cells. And specifically, they can be called keratoacanthomas, or a specific subtype of the squamous cell cancers on the skin. And like Dr. Pavlik said, we go in and we just take them off. And they're not like the invasive ones that we talk about just in general for skin cancer. Same pictures as Dr. Pavlik. So you can have the hand-foot syndrome with the calluses. You can have, again, these squamous cell cancers that just really need to be removed by a dermatologist. And so sort of how we manage these toxicities is also, again, on how severe they are. But for rashes, we use Claritin, we use Pepcid and topical treatments as necessary. And if needed, we give systemic steroids. Hand-foot syndrome is the same thing, like topical creams. The creams with urea tend to be very good at softening those calluses. Severe photosensitivity, more so in one set of the combination than the other. So really we recommend sunscreen, using a broad spectrum UV coverage. Just like Dr. Pavlik said, you want to make sure you get your lips, because most people forget that. And that's really where patients will come in with like blisters on their lips because of the photosensitivity. And also don't forget the extremities and the tips of your ears. That's the other place people tend to get sunburn. Some protective clothing, and really avoiding peak hours of direct sunlight. For these new squamous cells, we recommend just removal by a dermatologist. So for secondary malignancies, we're now actually starting to screen for these, right? So appropriate screening, so GYN exams, colonoscopies, dilated eye exams, and also oral exams, because some of these tend to be squamous cells. So not only skin squamous cells, but squamous cells of other origins. So really screening for those. We can see, like we said, joint aches, so acetaminophen, ibuprofen, and if needed, low-dose prednisone. For the fevers, they usually resolve. We hold the medication, give acetaminophen, take a break, restart the medication. If it occurs, you can consider dose reduction of the targets. And if it persists, we generally can pre-medicate with either Benadryl or Tylenol prior to taking the targeted therapies, and that usually seems to work. And if needed, we can also pre-medicate with low-dose prednisone, and patients can tend to stay on these therapies. And you can certainly have some GI symptoms, so antiemetics or antidiarrheals as needed, as well as diet changes, the brat diet. Okay. So I loaded the wrong thing. So essentially what is really, really important is good communication between your doctor and anybody, the support staff in the office, and you. And it's really a group effort. So letting us know specifically what's going on. Early intervention. We give patients wallet cards so that they know who to contact and when to contact patients. And we always send them home with patient-oriented information about the different side effects that they can experience so they know when to call us. So, thank you.